Right. Okay. So, my name is Georgia Malesi. I'm a pharmacist by background, a cancer pharmacist. And sorry, I'm just trying to put my slides on full. Perfect. Okay. So yes, I'm a cancer pharmacist by background, and I do all of my cancer pharmacy bits 4 days a week, and then 1 day a week I get to do this brilliant uro-oncology clinic where I work as a pharmacist prescriber, and I support patients with prostate cancer. So just to give you a little bit of the background of how this clinic works and how it was conceived. So around 10 years ago, we had sort of abiraterone and enzalutamide enter the market, and I was not part of the team at that point, but our urology teams and our pharmacy teams were very much cognizant of the fact that we were risking that our more elderly and frail patients might miss out on these treatment opportunities, purely because the oncology clinic setting might not be an appropriate setting for them. It's quite busy. And it might just not be something that suits these patients. As the role of pharmacist independent prescribers was being developed, I'm sorry, someone has their microphone on. Do you mind muting yourselves? Because the background noise is a bit distracting. Thank you. Oh, I think that's gone now. Thank you. Sorry about that. So yes, so it was very much realized that these patients were risking potentially missing out on treatment, and it's really interesting to hear in previous presentations that this is actually reflected to the metastatic hormone sensitive setting these days. My forward-thinking colleagues at the time set up a pharmacist prescriber-led urology clinic, so it's a half-day prescribing clinic and a half-day oncology clinic. So you had this ongoing conversation between the two specialities, and that pharmacist acting as a link between the two. So this is what the clinic pathway could does actually look like, and that's from the urology side of things. And as you can see, it's very much hands-on for me. So myself and my supervising consultant urologist who would receive a referral from the urology MDT or the urology CNS team, and I would get the patient into clinic. I would review them, obtain medical history, social history, drug history, review their blood results, review their scans where these are available, and then present the case to my consultant. We would then discuss as to whether any further scans or bloods are necessary. Any further investigations? Do we need to ask another speciality for a review, with this comorbidities or anything else like that? And then once we have collated all of the information together, I will bring the patient back in clinic. We will discuss any results, and we will obtain consent for treatment. I will then go back to my consultant and agree on initiating treatment, and then it sort of follows on with regular reviews with myself for the ongoing monitoring. And this is where I think a pharmacist is sort of best suited to use their skills for sort of a toxicity monitoring type of clinic where you're quite familiar with the medication, quite familiar with the toxicities, and it's just about sort of managing those toxicities while also ensuring obviously that you're managing the disease and monitoring for disease progression. So at the point of disease progression, I would then have a conversation with my supervising consultant to devise a plan of what we do next. So what have I found the benefits to be of this clinic setup? Well, I think it's a really good utilization of pharmacy skills. I'm not sure whether many of you are aware, but as of next academic year, the pharmacists that are graduating from from sort of university are actually coming out prescriber ready. So they do the trainee year and then they actually sign up as prescribers as well. So there's going to be this abundance of pharmacist prescribers out there, and actually in a time where there is quite a need for more healthcare professionals to be taking on advanced roles to support the entire prostate cancer care, I think that presents a really good opportunity to utilize pharmacy skills better. It's a better utilization for the medic's time. I'm sure this doesn't need any further explaining, but I do feel that clinical nurse specialists, pharmacy independent prescribers, and so on with the appropriate training can be really, really good in covering these roles, these toxicity monitoring clinics, and so on, and actually freeing up time for the consultants, for the medic teams to tackle the more difficult cases, tackle the new patients, the radiotherapy patients, the chemotherapy patients, and so on. I have quite enjoyed managing patients under sort of what I call the parent specialty, urology, particularly, well, for two reasons. Well, a few reasons, but I think the first one is that I remain very close to the urology speciality. So anything of a urological nature that I need sort of support or advice with, I've got my consultant, I've got the entire MDT, I've got the clinical nurse specialist sort of around me that I can tap into that resource, and it very much removes that follow-up burden from the oncology clinics. I can imagine that attending an oncology clinic setup is probably not the most pleasant thing, particularly for our patients that might be of an advanced age where traveling might be an issue to them, if it is about traveling to a bigger hospital. And it's all about this confidence of attending the big hospital where you have to, simple things such as having to find the correct lift, take the correct lift to the second floor, find the correct oncology clinic, and so on, versus the urology clinic that I run in sort of a single floor, little outpatient sort of clinic type of hospital, where even the actual access is so much easier. So it is all about improving access to treatment for patients, not just about physical access, ground floor versus second floor, but also what we saw earlier in the presentations about that bias perhaps toward age or frailty. It's about having more capacity within the services to make sure that we are not excluding those patients inadvertently from having access to these services. It's about improving continuity of care and concordance. Obviously, I get to see my patients multiple times a year to follow them up, and I think it's sometimes quite beneficial to build that relationship, understand what's important to them, what's their focus in terms of how they want to live their lives. Is it important to them that they remain very active to perhaps care for a loved one, or is it important for them that actually their memory is not compromised? Actually understanding what's important about for them to actually support them better in their treatment journey. I think another benefit that we have managed to realize through these clinics is, particularly as we have had more drugs enter the market and more complex funding sort of rules and regulations, is about sort of having that know-how to navigate those complex funding systems, and even as drugs are going on to generic, actually completing that transition to generic products and so on. And I think lastly, it's that quick access to oncology, urology advice and support as needed. As I said, it's quite easy for me to sift between sort of the oncology side and the urology side, as I work with both to get the correct level of advice and support for my patients accordingly. It's not all benefits, and it's not all rosy with this clinic. I suppose there are challenges that we are facing. There is obviously the ongoing question of expanding demand. So when I took over covering this clinic in 2020, we were working with 2 drugs under 3 NICE technology appraisals, and we were just having the metastatic hormone sensitive drugs sort of starting to cover ground, to take ground. And last time I counted, the NICE technology appraisals that we were able to offer were 9 or 10. So as you can imagine, numbers have trebled, and so on. So it's actually quite important that we factor this into any service development and service planning. There are complex funding criteria and deadlines, even for a cancer pharmacist. So as you can imagine, I suppose I will give you the example of metastatic hormone sensitive sort of funding criteria, where it says where the funding criteria state that we need to start treatment within 12 weeks of initiation of androgen deprivation therapy. As you can imagine, those 12 weeks can go very quick by the time that they have been seen, diagnosed, received their first dose, and then that onward referral pathway can actually cause quite a lot of pressure to make sure that we make the 12-week deadline. Meeting the patient expectation. Obviously, if we're starting treatment for a patient, we then need to make sure that we have that capacity to offer all of the correct follow-up appointments to look after them well. Non-medical prescribers requesting imaging, so not so much a challenge, but just perhaps something to think about if you think about implementing this at your hospital. If a non-medical prescriber is requesting imaging, they need to have a scope of practice and they need to be working within the RMA regulations. There's competing priorities for pharmacist workforce. I suppose, as you can imagine, the world of cancer services is only going larger and larger. Most of us are working in busy chemotherapy labs as well, where the chemotherapy is sort of put together and manufactured. So it's there's a lot of pressure sort of from all angles to make sure we are delivering the best care. And onward referral delays. So, going back to comorbidities, if there is a comorbidity such as a cardiac or a renal comorbidity, actually being able to access that service in a prompt manner in order to then carry on with treatment. So my reflections, having sort of done this clinic, and I suppose as I was typing up the slides, I think it's really important that we utilize each member of the multidisciplinary team to the top of their license, thinking not just about the pharmacist, the clinical nurse specialist, radiographers. There's very excellent resources within the multidisciplinary team that can support service provision, particularly as the demand is only increasing. But with that, we need to have a very clear scope of practice and governance arrangements to almost be clear and sure about what is the scope of practice of everyone, where do I need to refer onwards, and so on, just so that everyone is feeling quite happy and secure within their scope of practice and has a clear pathway of referring onwards if they deem that necessary. Continuing to develop the framework. As I said, we went from 2 NICE technology appraisals to 9 in my time in clinic. So we cannot keep working on the same model. We need to constantly think about how we adapt the model to continue sort of delivering that service that we're delivering with increased demand. And then obviously the matter of ongoing funding. I think it's quite important that we have these conversations quite proactively within our teams to ensure that we secure the ongoing funding required for service development. So that is the end of my talk. I'll mute myself now and I'll hand back over to Chair. Thank you.